endotracheal intubation, or ETI Oral. ETI is a highly invasive procedure that can result in complications for the patient later. However, it is a definitive treatment for securing an airway to prevent aspiration of blood or vomitus that may be present and not controlled by other means. It is an indicated procedure in patients where there is a need for ventilatory assistance or airway control, and other airway management is inadequate or ineffective. Prior to moving to ETI to manage the airway and breathing, less invasive procedures, including manual maneuvers, oral or nasal pharyngeal airways, and King LTs, should be attempted and evaluated for efficacy. Lay out your equipment in the order in which it will be used through the procedure. Equipment required includes a laryngoscope handle with laryngoscopy blades appropriately sized for the patient. Millers or straight blades are often used with pediatric patients or adult patients who may be spinally immobilized. Macintosh or curved blades are commonly used with adult patients who have mobility in the neck that allows for alignment of the cords to enhance visualization of the glottic opening. Please note, ETT selection depends on the patient's size and airway conditions. Generally, older children, smaller adults, and/or females can accept a cuffed tube of 6.0 to 7.5 millimeters, while larger adults and/or males can accept a size tube of 8.0 to 9.0 millimeters. You also have to consider if there are anatomical structures, such as throat tumors or airway swelling, that will require you to use a smaller ET tube. For children, ETTs range in size from 2.5 to 5.0 millimeters and are uncuffed. Proper sizing can be calculated using the formula of age in years divided by 4 plus 4. For example, based on this calculation, a 1-year-old should accept a 4 to 4.5 ETT. Because these ETTs are uncuffed, they are easily dislodged without detection. Ensure uncuffed ETTs are secured with tape, are constantly monitored, and placement frequently reassessed. Initiate airway management with an oral pharyngeal airway, bag valve mask with filter, and with end-tidal CO2 adapter in place. Assign another paramedic to monitor and maintain oxygenation and ventilation of the patient while you prepare and lay out your equipment needed for this treatment. This includes application of all monitoring tools if not already in place: cardiac monitoring leads, SpO2, and end-tidal CO2. Assemble the laryngoscope, lidocaine spray, ETT with a syringe attached to fill the cuff, stylet in the ETT, suction, and a tube securing device. In this demonstration, a commercially prepared device is used. Ventilation stops while laryngoscopy and ETI are done, and the patient's oxygen saturation level will immediately begin to drop. To minimize the risk of oxygen saturation dropping below acceptable levels, be prepared to initiate ventilation quickly and proceed with the ETI in steps. Here, Here, the paramedic is preparing for his first look at the cords to determine the difficulty of the airway, is suctioning any fluid from the airway, and is spraying a topical anesthetic, lidocaine, to the back of the oropharynx and the glottis to minimize gag response and laryngospasm. Once done, the OPA is reinserted and ventilatory support is continued. If required, and there are available resources, cricoid pressure may be utilized to minimize gastric insufflation during positive pressure ventilations with the bag valve mask. This procedure is accomplished by applying pressure to the cricoid ring directly posterior and occluding the esophagus. After reoxygenating the patient, initiate another laryngoscopy to attempt the ETI and position the head with moderate extension into the sniffing position. Manipulation of the thyroid cartilage is often helpful to improve visualization of the glottis. This procedure is accomplished here with a second paramedic who applies pressure to the thyroid cartilage in a distinct backward, upward, and right motion. Once the cords are in view, introduce the ETI and advance until the cuff has passed the cords. Insert another few centimeters to position the ETT in the mid-trachea, sitting above the carina and well below the glottic opening. Note the distance marking on the tube at the teeth or gums. Remove the stylet and inflate the cuff until the external pilot balloon is full. Maintain manual control of the tube. With the assistance of your partner, attach the filter, end-tidal CO2 and bag valve mask to the ETT and confirm its placement. This includes auscultation of the chest, observation of equal chest rise and fall, misting in the tube, and obtaining an end-tidal CO2 numeric value that is displayed on the monitor. Once the tube placement is confirmed, secure with the tube tie device. A tube extender can be added between the end-tidal CO2 adapter and the BVM to allow for the bag valve mask to be placed beside the patient during transport without tugging on the tube. Lastly, display the end-tidal CO2 waveform on the monitor screen for ongoing monitoring.